All right. So it's 12:05. I'll just go ahead and start. Welcome everyone to the Ryan White public hearing, and thank you for joining us. And I hope that everybody's doing okay. Just a few sort of virtual housekeeping pointers. When we start the presentation, I will be muting everyone except for the speakers. I mean, you're free to unmute yourself if you want to. You'll be able to do that. And then at the end of each, so we'll have 4 parts to the presentation. And after each part, you'll be able to ask questions to the presenter. And at the end, we'll have another Q&A sort of session. You can raise your hand during the presentation if you wanted, if you felt like something is urgent and you needed to raise your hand. And then there's a chat box where you can, if you think of a question and you think you might forget it, just go ahead and type it into the chat box, and Tyler Burrell will actually ask all the questions in the chat box at the end of the meeting. Other than that, we'll just go ahead and jump right in. Okay, and then we'll start with Stanley's presentation, and you can go ahead and unmute yourself, Stanley, and then we shall start. There you go.
Can you hear me?
Yes, I can.
Okay. All right. I'd like to welcome everyone to the Ryan White public hearing for fiscal year 2019. Like Suzanne said, if you have any questions, can you please type in all your questions in the chat, even if you want to raise your hand, so to give us a better opportunity of having those meeting minute notes. All right, Suzanne, can you go to the next page? All right, the Ryan White program, it's the Treatment Extension Act. It's a federal program designed to address gaps in care for people living with HIV. It's a source of funds to support care and services to enhance access to retention to HIV care. Next slide. All right, the goals of the program are to reduce the use of more costly inpatient care, increase the access for care for underserved populations, and improve the quality of life for those affected by the epidemic. Next slide. The need for the act, it's to serve people who don't have health insurance, people that have insurance that doesn't cover all of their needs. So the Ryan White program will wrap around those coverages. So if your primary healthcare insurance covers part of your service, Ryan White will wrap around it if it's approved service for Ryan White. If you don't have insurance, if you need a service that Ryan White covers, we will cover that 100%. And please remember that Ryan White is payer of last resort. For fiscal year 2019, our funding was $4.7 million. Our fiscal year starts April 1st, ends March 31st. The funding is distributed in the following manner. We have base funding at $1.9 million, AIDS Drug Assistance Program, which is ADAP, at $2.5 million, Emerging Community at $192,000, Minority AIDS Initiative, $39,000, and the funds are allocated core services, 75%, and support services, 25%. Next. All right, core services, which are 75%, are outpatient ambulatory care, that's your medical care, AIDS Drug Assistance Program, that's your medications, oral health care, that's dental, early intervention services, health insurance, home health, hospice, mental health, and medical case management. Our support services, which make up 25% of our funds, is non-medical case management, emergency financial assistance, food bank, housing services, medical transportation, outreach, referral for health care, and treatment adherence counseling. The contractors that we have for the Ryan White program are Christiana Care, that's medical services, Delaware HIV Consortium, they provide HIV support services, HIV case management, planning council, AIDS Delaware, they provide HIV case management and transportation, Ken Sussex Community Services, they provide HIV case management and early intervention services. Beautiful Gate Outreach Center, they provide early intervention services, Minority AIDS Initiative, and transportation. Latin American Community Center provide early intervention services. Ramsell Public Health RX They're our pharmacy benefit management company, and they also provide health insurance program. Seven Keys Consulting, that's Mr. Glenn Pruitt. He provides our quality management. The demographics for our program for the clients in 2019, total amount of clients is 1,651. The majority of our clients are ages 45 to 65. They make up 61%. The next largest range of clients is ages 25 to 44. They make up 30% of our caseloads. Males are the majority of our clients at 63%, with females coming in at 36. Transgender is 1%. All the clients that have an AIDS diagnosis, that's 60%. And a majority of our clients reside in Newcastle County, and that's at 65.6%. And at below, you'll see our insurance breakdown with Medicaid having the most of our clients, that's 721 clients out of 651. Next slide. Does anybody have any questions for me, or you could type them in and we can answer them at the end?
I guess I have a general question. Are all the charts going to be made available? There are some good statistics there.
Are all the what?
All the charts that you showed, are they going to be made available?
Yes, yes.
Okay, cool. Thank you.
Yeah, Suzanne has them and she'll send them out. Yeah.
Perfect. Thanks.
You're talking about the presentations, right?
Yeah, there were some good numbers and statistics. Thank you.
All right, good.
Sure. I'll send them out after we're done. If there are no pressing questions, we can move along, and then if there are any other questions, we can ask them at the end. Next, we will go to the Holloway program, and I will unmute you, Arlene, and you can go ahead and start whenever you're ready.
Thank you, Suzanne. And thank you all, everybody, for joining us today. So I'm going to give an overview of the Holloway program, but I also I'll be inserting some commentary on our current state versus some of the information that would have occurred last year before we are all being faced with modified work schedules and triaging of patients. So as I think everybody knows, the Holloway program is the only Ryan White funded medical provider in the state of Delaware. We are a statewide program. We have multiple sites throughout the state. However, I'm going to say that at the current time, 2 of the smaller satellites in Wilmington, both Beautiful Gate and our Lancaster site, which is part of Brandywine Counseling, we are not providing medical care at those locations at the current time through the COVID epidemic and pandemic. We will be establishing our care once we get past where we are right now. And before I start talking a little bit about the sites, I do want to emphasize that our providers are going through their patient schedules. We are working on a modified schedule as far as medical care is concerned. Our providers are triaging all of the patients on their patient schedules. They are either moving them forward and doing appointments that would be scheduled later in the summer if that patient is stable and doing well on their HIV medications, or they're doing phone visits, or we are still seeing people. We are still seeing patients that need to be seen, and we are still getting new referrals and engaging new patients or re-engaging patients into care. So I want to make it clear that although we are operating under a modified schedule, we are not closed for business. We are still here and we are still taking care of our patients. And this is true at all of the locations. So right now, we are seeing patients at the Gateway, which is in Wilmington. We are seeing patients in Smyrna. We are not physically going to Westside Dover at the moment, but we are collaborating with our good friends at Westside, and we are still open in Georgetown. Next slide, please. So last year, in 2019, and I'm talking a calendar year, we saw 1,724 unduplicated HIV positive patients. That's throughout the state. And you can see the demographic breakdown. So 69% are male, 30% are female. We have 1% transgender, 60% are Black, 25% white, 8% Hispanic. MSM is 35%, IDU 12%, and heterosexual transmission is identified in 50% of our patients. 41% of our patients have Medicaid, 25% Medicare, and 27% have private insurance. Our uninsured is about 5.56%. It kind of varies from month to month. And in many cases, those are patients who are undocumented and not eligible for other services. I will say that in last year, we had 164 new cases. Now, again, that's not necessarily newly identified. That could be people re-engaging and they've been out of care for a couple of years. It could be people who are not newly identified but have transferred or moved into Delaware. It could be people who are newly identified. Usually it's about 50% are newly identified and the other 50% are transferring. You can also see that we have hepatitis C patients, that's on the top line, and PrEP patients for pre-exposure prophylaxis. And that's an additional 153 patients that we saw in 2019. I do want to again point out we do not use Ryan White funding for patients who are HIV negative, which would be our Hep C population and our PrEP patients. But I think it's also important to articulate that those are services we do provide. Some of the clinical outcomes that we are particularly held accountable to by HRSA are how many people do we lose to care? At the end of the year, how many people do we not know where they are? In other words, they haven't been retained in care, and that's less than 1%. So that is a really important number because we obviously are not going to be doing good treatment if we can't keep people engaged in care with us. And all of you that are in the HIV service delivery system, succeed and own that outcome because your supportive care is what helps us keep people in care. 99% of our patients are on antiretroviral therapy, and our undetectable viral load rate is actually pretty close to 90%, which is the target. That is the goal. Next slide. We also have a number of other services that we provide to our HIV positive patients. So we do obviously HIV primary care, but we also provide internal medicine management for patients who have complicated diabetes or cardiac disease or asthma, patients who really kind of can't navigate doing more than one provider. So we integrate that service into what we provide. We have our own OBGYN provider who is Ryan White Part D funded, and we provide OBGYN care to our female population. We do adolescent transition with Dr. Stephen Epps. We have mental health services, as Stanley already articulated. That is with our full-time psychiatrist, Dr. Tony Ducray, and 2 LCSWs. We have our PharmD visits, which are adherence visits, and that's our pharmacists who run that program. And again, as I said, we do nursing visits, we do hepatitis C, and we do PrEP. So total number of visits in excess of 10,000 last year. Next slide. So ADAP medications, our part of Ryan White Part B funding as a subrecipient with the state is for patients who are on full ADAP, have no other coverage, and that's a little bit excess of $2.8 million. And then we also get funding for core medical services, both here at Gateway, in Smyrna, and in Georgetown. And we get funding to support our adherence program with our PharmDs. Next slide. I think it's important to also just take a moment to talk about Ryan White Part C and D. These are, we are the direct recipients of this funding. We are not a subrecipient as we are with B. This is an independent grant with HRSA through a competitive application process. It has a May 1 to an April 30th budget period. We just got word that we have to submit a competing application in June, so I'll be starting to work on that. That also provides funding for core medical services as well as mental health services statewide. And that funding is a little bit shy, as you can see, of $900,000. So it's a relatively small project. Next slide. And we also have Ryan White Part D. Ryan White Part D is what we call WICI, or Women, Children, Infants, and Youth. It too is an independent grant with HRSA through a competitive application. Interestingly enough, this one has just been extended for a 2-year period, and HRSA is undergoing a comprehensive evaluation of WICI. It'll be interesting to see what they ultimately decide, or whether they're going to reconfigure this at all. but right now we're extended through the year 2022. It has a little over $400,000 worth of funding, and it really provides funding for our women's health program, for pregnancy management, for coordination of follow-up care for infants born at risk, for the transition of adolescents, and the HIV medical care of youth. So, and there's also adherence support for the WICI population to improve clinical outcomes. Last slide. So we have undergone and are about to undergo a ton of changes in keeping with a lot of what you all are seeing as well. In 2019, we implemented Cerner ambulatory electronic medical record. That was a huge change for us. It is the same medical record, only a different platform than what they use inpatient at Christiana Care. And there were a lot of challenges associated with Cerner ambulatory. It is not exactly the best platform for team-based care. So we continue to do workarounds on that to make sure that we are communicating amongst ourselves and making sure that our patients are getting the comprehensive care and services that they need. In January of this year, we were very lucky to have another full-time ID physician join us here at Gateway, Adam Skrinsky. Adam comes to us from New Jersey. He is a very experienced HIV and Hep C physician, and we are really, really excited to have him among us. He's doing a great job. We've had a number of retirements. I think a lot of you know that Joni Miller has retired. Pat is going to be retiring the end of June. Robin's retiring the end of September. I do not have enough hair color for all of this, but we're going to get through it. And we have a number of really good people that are going to start working with us. And we're going to be going under some transitions, but this is part of moving forward. Dr. Scotto in Georgetown, our full-time physician, is actually moving to Florida. I'm not quite sure what prompted him to do that. We tried to tie him down, but he was a little resistant. So actually his last day in Georgetown is today. So we're going to wish him well and thank him for all he's done for us and for the community. And we're very lucky that Kara, many of you know Kara Grove, she is a nurse practitioner. She is going to be joining us full-time in May. She'll be our full-time nurse practitioner in Georgetown. And we're also extremely lucky to have Dr. Eric Halpern, who many of you also know, as doing primary care both in Smyrna and Georgetown. So we've been able to build that, and we're very blessed to have him with us. So in addition to all of these other changes, we are working with our providers and with our staff and with the community and with the Division of Public Health to not lose sight of the HIV epidemic, not let our patients falter, not let our viral load suppression rates rise. COVID-19 is an extremely important thing that we're all dealing with, but we want to make sure that at the end of the day and 6 to 9 months down the road, we're not sitting here and looking at an HIV epidemic that has started to climb again. So we all need to keep our eyes and ears and support our patients and support each other. So thank you.
All right. I have 2 questions and then one for myself as well. So I think this first one is for Stanley, but I think it's applicable to all the presenters today. It was from Dr. Luda. Can we present the Ryan White usage per capita? With the population distribution of the state, and Newcastle County will always be at the top, but this may mask actual need, is as he put it.
So Martin, are you asking for how much per client for the whole year? What the cost is? Is that what he's asking?
It's not. He doesn't say if he can unmute himself or I can
unmute him.
Okay, go ahead, Suzanne.
There you go.
Can you hear me now?
Yes.
I can hear you now, Martin.
Right. So basically what I'm driving at is the per capita display of the data, because if you look at the proportion of folks, let's say in Kent, that are using Ryan White, if you tabulate that per 100,000, then it might be a more representative way of looking at usage rather than looking at overall percentages as we are looking at it right now, because Newcastle will always be a huge representation of the current data. Am I making sense?
Well, that's the way it's going to represent in all of our, when we break it out, because in all the different programs, there's always going to be more in Newcastle County. Is that what you're saying?
Right, and what I'm saying is the way it is right now, we really can't know. There may be more need for Ryan White use in Kent, but because the population is so much smaller, it will always appear like it's a smaller proportion of the overall need. But if you convert what you are presenting to be per capita, then it will be a more representative of the actual usage. I hope I'm making sense.
In the 5-year plan, we have it broken out per county, per service. So, for example, we know in Kent County and in Sussex County, there's more of a need for transportation than there is in Newcastle County, even though there's less clients in those counties. Is that what you're asking? Something like that?
Not really. You see, for example, if we say there are 200,000 people in Kent County, and there are 600 people in Newcastle County, if you convert the actual usage of Ryan White services to be per 100,000 in each of those counties, then it will be more comparable.
Okay. All right. We can look at it that way.
Yeah. See what you can do.
Okay.
All right. So I have another question here from N. McGee. I'm sorry, I don't have the first name there, but
Nancy.
Nancy, fantastic. And this is for Arlene. What prompted the reevaluation of the Ryan White Part D, the Wiki program? What are they assessing?
And that's a really good question. So there was conversation a couple of years ago about actually merging C and D because other than pregnancy management and some components of women's health, as the Ryan White provider, we are really tasked with providing comprehensive primary care as well as HIV care. So what I'm trying to articulate is the services vary from patient to patient depending upon need and depending upon their medical status. And it doesn't matter whether you're male or female. We provide the services you need and we're held accountable to certain clinical outcomes. So I think HRSA was looking at wanting to combine the funding because a lot of Part C grantees are also Part D grantees. However, that was precluded by the current legislation. So I think what they're looking at now is whether or not there is a way to combine those funding streams without violating the legislation. But I think they're also looking at what specific are the clinical outcomes that you would want from a wiki population that doesn't apply to Part C. They actually did evaluate Part C a couple of years ago. They redistributed funding based upon caseload. There could be some of that they're looking at with Part D. They really weren't real clear other than to say that they were going to extend every current grantee for 2 years and evaluate the program as to its efficacy and what its structure needs to be. We may find out more. There is an all grantee meeting currently still scheduled for August in Washington. Stan and I'll both be there. We may find out more of what they're looking at or what they've been evaluating when we go to that, but I don't have any more specifics for you at this point.
She follows up with that is there a need for advocacy here?
I don't think there is until we know what they're doing. I mean, right now we don't have a lot of details, right, to know. They're not talking about eliminating it. They're talking about how to structure it more efficiently or how to make sure that it is meeting the needs of communities.
And that kind of leads into my question, which I'll type in the chat box after this. But is there? I know this is all hypothetical right now, but is there a concern that with regular assaults on funding for Planned Parenthood and whatnot, that any reallocation of dollars from Part D would make a gap in your budget for services for women and children who get health care in your program?
Well,
you know what I'm saying?
I do know what you're saying. We have suffered budget cuts over the last 5 years in C&D, and any budget cut creates a challenge for us. But having said that, I think the flip side is that we are very blessed to work with an organization that understands that the Holloway program is a very important part of the mission of taking care of the needs of the community. So we have been lucky with that support. Now, having said all of that, the impact that the COVID pandemic is going to have on healthcare organizations remains to be seen. So, you know, am I held accountable to profit and loss and budget outcomes? And are there certain restrictions as an organization? Of course. But, you know, so far we've been very lucky, and I don't believe the goal is to eliminate the funding for Part D. That is certainly not what happened with C when they reevaluated, and I don't think it's going to be what happens with D either.
All right, thank you so much, Arlene. If there are no more questions, we'll move along, and we will have Brad Shannon. Mute Brad. Oh, there you go. Go ahead and start.
Well, good afternoon, everyone. I'm in a love-hate relationship with these conferences. We have a lot of conference calls and video conferences, and I get tired of them, but at the same time, I'm really glad that we have them and can keep in touch with one another. Today, I'm going to be talking about the client usage of our housing and EFA and mental health and transportation programs. So for calendar year 2019, there were just under 1,700 clients engaged in Ryan White case management. Of course, everybody accessing any service has to be engaged in case management services. And the gender breakdown is pretty stable, with about a third female and about 2/3 male. And we have exactly the same number of transgender people as the previous year. Our racial breakdown is pretty similar to a little under 2/3 for African Americans, a little over a quarter for whites. I want to point out that Asians do not appear on this list, not because they were forgotten, but because there was no individual living with HIV who identified as Asian. For the EFA program last year, we spent approximately $85,500. This program was accessed by 234 unique individuals. That's about 1 out of 7 of all of our case management clients had some need for emergency financial assistance last year. Our housing program receives $333,000 in Ryan White Part B money. These funds augment our HOPA funding for rental assistance that we receive from HUD. I think the Ryan White Part B counts for approximately a quarter of all of our funding. And we were able to help 151 individual households last year using the Ryan White Part B funds. And that's about 1 out of every 11 people in Ryan White services. Mental health. So last year we spent a mere $900 on mental health. It's a very, very underutilized service that is offered. We have a listing of mental health providers in all counties. And it's a direct reimbursement. It's a pretty simple program for the provider and for the client. This, I think, is worth exploring. I know that mental health comes up as an unmet need every time there's some sort of assessment done. So we hear from people living with HIV in Delaware that access to mental health services is a need, but then we're not seeing a lot of utilization, at least through this particular program. For transportation, we spent close to $54,000 last year. About 1 in 15 clients access this program. We continue with our one provider in Newcastle County, that's Beautiful Gate. and our one provider in Sussex County that is through AIDS Delaware. Our provider in Kent County stopped providing services at the end of the last fiscal year. So currently, for the last year, I guess, we have no transportation provider for the middle of Delaware. Next slide. And questions. We were originally scheduled for St. Patrick's Day, so that's why it's a little festive here.
Do you have any questions from the chat box, Tyler?
No. Okay. Actually, one just popped in. Okay. The question here is from Frank Hawkins, and it's in regards to the housing program. Of the 151 individuals and families, how many retained their housing? What is the process for housing readiness? I'm sure on the wait list, making sure they're ready once their name comes up on the list.
Right. So every year for HUD, we have to do a very long and comprehensive report called the CAPER, and we do address retention either in our program, or sometimes people leave our program, but because their lives have improved financially and they still have stable housing. I don't have those numbers readily available, but I can tell you it's well over 90%. And the housing readiness, we conduct it pretty much like it's one program. So the case manager submit an application on behalf of the client, and we make sure that they meet the requirements, that they're a resident, they're a person living with HIV, that their income is below 80% of the area median income, and we move them from the waiting list into the program. And I'll say we've done a really good job with that. This last year, our waiting list for Kent and Sussex counties, which is largely funded by Delaware State Housing Authority, we had reduced to 0. I think now there's 3 or 4 people on that waiting list. And the waiting list for Newcastle County, which is largely funded by HOPWA through the city of Wilmington for the entire county, we were able to reduce that waiting list by more than half.
So just a follow-up on that, there is a request from Dr. Luda. What is the waiting list? You answered the Kent and Sussex County, but do you have a sense about what Newcastle County is?
Newcastle County, I'm gonna say, is somewhere around 95 currently.
Okay, and then he follow-ups, and I'm coming back to Frank after this, but he followed up with, do we work with House of Joseph in Wilmington?
Well, House of Joseph helps take people from homelessness into their community setting. So they do something different. We provide rental assistance to people out in the community.
Okay, and then just following up with Frank, and he was in reference to housing readiness. This in addition to that, he was wondering is if a client is on the list and they have a huge electric bill, then what can be done or what is done? While they're on the wait list, excuse me.
Yeah, so we recommend, because people are usually on the wait list for at least a year, up to 2 years, that the client and their case manager work together to find resources to lower their outstanding utility bills. And the reason for this is when folks enter the program, they're required by HUD to have utility services in their own name. So I know some folks have, say, an old electric bill that's a couple of $1,000s. They will need to pay that off before they could be a participant in the program.
More questions?
I think that's all I have in the chat box.
All right, we'll move along. And we have Mr. Glenn Pruitt, who will share with us a little bit about the quality management activities. Unmute. Why is it not? There you go.
Great. Thank you so much.
Mhm.
Often when we talk about quality, and we think about it in terms of individual services, and the questions tend to be, do we do a good job providing the service? And do our clients like the service they get from us? When we look at the quality management team's work, we really step back and look at the bigger picture. And that bigger picture is, why do we provide any of these services? It's not that so clients will be satisfied. It's so that clients will have better health outcomes. And so the quality management program really looks at clinical benchmarks for the success of all of the services that we provide. And those services range from HIV medical care to HIV medical transportation. And each service has value of its own. It doesn't matter if you have a good medical facility if people can't get a ride to get to it. And conversely, it doesn't make any difference if you have wonderful transportation services if you aren't taking them to a high quality provider. So we all work together to try to achieve the best health outcomes for our clients. Delaware's quality management program really has three major components. The first one is our quality management team. This was a team that was established in 2013, so we've been around for a while now. The committee is made up of representatives from a number of different providers and parts of the continuum of care. And as I said, we review these performance measures, which we're going to look at on the next slide. Another function of that group is to engage in some quality improvement projects. And these are interventions that hopefully will impact the system on a broad level so that we can improve some of the performance measure scores that we see. And third, we have the Plan Review Committee, which is 5 people who are monitoring our success or our challenges in implementing the 5-year integrated HIV prevention and care plan that we passed back in 2016. Next slide, please. So I was talking about these clinical performance measures, and these are some of the ones that we look at most closely. These numbers are actually from November 2019. Just today, about an hour ago, I got the ones for the first quarter of this year. So I'll glance over and look at that from time to time. But some of the things that we look at as performance measures, we look at whether clients have 2 primary care visits greater than 3 months apart in the previous year. So this is a way of measuring, are they getting in and getting primary care? The goal is 80%. As of November, we are at 76.4. HIV medical visit frequency is whether a client has 2 medical visits 6 months apart over a 2-year period. So this is trying to gauge ongoing participation in HIV medical care. This is an unforgiving measure. If a client makes their medical visit at 6 months and 2 days, doesn't matter that it was close, they don't meet that standard. So you can see our target percentage is 75%. Currently, we're at 64. Though as of last week, we've now gotten that up to 72%. Viral load suppression is a snapshot at the reporting period of how many of our clients have a suppressed viral load for HIV. Our goal is 80%. We are at 87%. So we are overachievers, though we are continuing to push on because we want to get that one up to 90 ultimately. Durable viral load suppression takes that one step further. This would be clients that their last 2 viral load tests came back as being undetectable. Again, our goal here is 75. We are at 67. Linkage to care within 1 month of diagnosis is pretty straightforward. How quickly do we get people, once they know their HIV infection, into HIV medical care? Our goal is 85%. In November, we were at 75% as our performance. The challenge with this one is it's good news and bad news. The good news, we have very few new infections. So the number of cases we're looking at is small. the challenge with that is if you have 1 or 2 people who fail to make that mark, then your percentage drops very dramatically. The other piece of that is if you extend it out, instead of looking at 30 days, if you look at 37 days, 1 more week, our percentage goes up significantly. So we're doing a good job. We could always do a little bit better. Next slide, please. We are also looking at some additional performance measures because we're wanting to look at all of the services that are funded through Ryan White Part B. So this is a list of some other ones that are not clinical outcomes, but are more process outcomes. We are working right now of trying to figure out how to define them clearly, to quantify them, and then how to measure them. A good example of a challenge for that is the dental ones. Dental is a highly funded service in our program, about $1 million a year. But tracking whether all clients are being appropriately screened for dental care and whether they're getting their treatment plans completed is a little bit challenging since we only have access to the bills that are coming in. So Doug and Trader and the team are looking at how can we quantify that and determine what our success is there. Eligibility recertifications are how timely recertifications are done for the Ryan White program. That's something we've looked at a lot in the past years. Continuity of care planning is defined as having 2 or more care plans done 3 months apart, sometime within the previous 12 months. So we're coming up with some of these definitions and we're figuring out how to measure them on an ongoing basis. Next slide, please. As I mentioned, the quality management team also tries to do some interventions to try to improve our health outcome percentages. At the beginning of 2019, we really were focusing on mental health needs. Brad Shannon touched on that briefly in his presentation. We kind of know there are some challenges with getting people into care, but what we think we know and what we can prove sometimes can be 2 very different things. So the quality management team started reviewing data, particularly from the medical monitoring project. And we discovered that only 16 out of 340 patients said that they needed mental health, sorry, there's an extra Y there, mental health services, but didn't receive them. So that's less than 5%. But that's a big number for those people that fall in that 5%. We found no discernible pattern for barriers except for stigma. And particularly for mental health services, you have the double stigma of people living with HIV and people living with mental health challenges that sometimes prevent them from even seeking out services, or if a referral is made, for them to actually follow through on the referral. After looking at this for about a half a year, we decided that stigma is probably a little bit bigger barrier than what our team can manage. So we've decided now to focus on dental services, which I mentioned is highly funded by Ryan White. Right now we're in the data collection phase where we've been doing some case management chart reviews, looking at more MMP data and looking at fiscal data. And so that will be our focus for 2020. Next slide, please. For those of you who come to the HIV Planning Council meetings, you already know who the Plan Review Committee is. This was a team that was set up when we approved the integrated plan back in September of 2016. They really have 3 major tasks. That's to keep everybody in the loop about what's going on with the plan, to identify any challenges being encountered in the implementation of the plan, and to engage in some problem solving for those challenges. We report back to the HIV Planning Council twice a year, typically in November, which if you were at the November meeting, I did a presentation there, and typically in the spring. So that's today's presentation is going to be part of that requirement. Next slide, please. The current membership of this committee, some of us are on the call today. Stanley Waite represents the Ryan White Part B program for public health. Bob Vella is from HIV prevention. Jim Dowling from HIV surveillance. Suzanne Abdallah is representing the Planning Council, and myself representing our quality assurance program. Next slide, please. If you haven't read the 5-year integrated plan lately, or you haven't read it at all, it's a very large document, 104 pages long. The actual section of activities and timelines is 25 pages. I am not going to go through that today. I hear everybody cheering in the background. Thank you. But I do want to remind you about what the overarching goals are for our plan. Goal number 1 is to reduce new infections. Number 2 is to increase access to care. And number 3 is to reduce HIV-related health disparities. And all of our activities feed into how do we achieve success with those goals. Next slide. The plan has 84 different activities. We've been working on this now for the last 3 years. At this point, all of our activities have started, and many of them we've actually completed. And each activity is assigned a monitor from the 5 people who are on the plan review committee. Next page. I'm going to highlight kind of what happened in 2019. I'm going to tell you 2019 was not a great year for us. We are experiencing some challenges that is just motivating us to work a little bit harder. One of our activities was to develop a collaboration between the Planning Council, the Department of Public Health, and school districts to address sexual health and drug prevention education programming in our schools. We did some preliminary work, developed an assessment tool. We actually had some success with 1 school district. We were hoping to do 3. And don't forget, there are like 19 in the state. But we certainly encountered a lot of resistance from the Department of Education. So right now that is on hold. Doesn't mean we'll let that go, but we, as I said, timing is everything, and sometimes waiting is a very valuable strategy. Next slide, please. We wanted to develop some interventions about retaining vulnerable populations, particularly those that cycle through our system, where they're in care and out of care, because they are dealing with competing priorities, a lot of them about dealing with life crises and that they're individually experiencing. This is something we didn't plan to have done until 2021 anyway, but we started it. Our biggest challenge is we all seem to know who, anecdotally, who we think these people are that cycle in and out of care, but really trying to define it objectively is a lot harder than what you might think. This was a topic we were going to discuss with our HRSA reps during their site visit last summer. That site visit was postponed and has not been rescheduled yet. Next slide, please. Many of the activities in goal number 3 about reducing health disparities are still on our timeline, but our deadlines have kind of shifted. Part of that was we were waiting for the latest epidemiological profile to be issued from Delaware. That came a little bit later than we had originally projected when we created the plan 3 years ago. We do have that in place now, and we are starting to work with our surveillance folks to identify subpopulations that might benefit from targeted interventions to help them either get into HIV medical care or to maintain their participation in care. Next slide, please. I do want to highlight a couple things that have been going on that we've had some success. We did implement some integrated funding contracts, and this is where we're having our prevention side and our treatment side actually work together to achieve some synergy and also to reduce some administrative work on the behalf of our service providers. So that's a good thing. We are in Delaware lucky to have our HIV prevention and treatment programs literally in the same office suite. So those staff members interact very frequently together. And that really is a springboard to great collaboration. As I said, we explored some funding opportunities around case management. We have done that. Stanley Wade has done a great job in finding additional resources for case management services statewide, particularly as our dollars from Medicaid continue to dwindle. And we have highlighted some hot button topics in meetings. Some of the things are in the integrated plan. We've brought them to the Planning Council and its work groups for discussions, including PrEP, mental health, and stigma. Next slide, got it. We did provide some HIV-specific training about for our partner services workers. on partner elicitation information and motivational interviewing. Our goal is to increase the number of people we identify through partner notification. And we've had some real success there with looking at clusters of new infections, and additional training will be offered in 2020 for those staff people. One thing that is not in the slides yet, but I do want to just highlight though, is one of our new activities this year. If you're ready for it, it's actually time for us to start working on the next 5-year integrated plan for prevention and care activities. So I know the Planning Council will be asked to start providing even more robust participation as we start to plan that document and lay a roadmap for how we're going to treat the HIV epidemic in Delaware in the next 5 years to come. Thank you.
Great, thanks, Glenn. I have a few questions for you here. First, from John Gardner from the beginning of your presentation. He's wondering who is on the quality management team currently?
The quality management team currently, our membership is a little fluid right now as we've had some attrition of providers. But the quality management team right now includes Stanley Wade and Doug Trader from the Division of Public Health, Robin Bidwell from Christiana Care, Brad Shannon from the Delaware HIV Consortium. We did have Caitlin Baskerville from Kent Sussex Community Services, but with KSCS closing its doors last month, that position is now vacant. Jim Dowling and Bob Vella from Surveillance and Prevention are on the team. And we always are trying to recruit a person living with HIV to participate in the committee. We've had over the years a number of people come, but they tend to come only 1 or 2 meetings for good reasons or not. It's a difficult committee for, I think, the average consumer to understand what we're doing. So there's a lot of mentoring that needs to take place. That's something we will continue to strive to do, is to recruit consumers.
All right, this one came from me in reference to the clinical performance metrics. I was questioning who is setting the performance metrics benchmarks. Is that a federal set benchmark, or is that us that are setting those benchmarks?
That's a great question. Actually, our quality management team set those benchmarks, and they are actually higher than many of the national benchmarks. Because we wanted to give ourselves stretch goals, something to keep working towards. So it would be, next time I do this presentation for the Planning Council, I'll pull in what the national averages are for those same performance measures, so we can see how we are doing compared to other states. That's a great idea, thank you.
Great, now we have 2 questions from Nancy McGee. And the first one is in reference to the dental services that your quality management team is looking at. The first is access to dental is near impossible in other areas of care for adults. What is the secret for those treating those living with HIV? What dentists do we work with?
I certainly can relate to that. I go to a dentist in Maryland, not even in Delaware. We have a limited number of dentists that the Ryan White program has established a good working relationship with over the years. They are not many. For the most part, we are lucky that we had a dental clinic in Wilmington, Pierre Toussaint, that was providing a lot of our dental care. It's always a fluid number of providers. We don't have a secret for success. And I think that's one of the things we're going to be trying to assess as we do our work in 2020 is how do we recruit other providers, and how do we make it easier for consumers to get dental services that they need.
All right, great. And then I have a last question here also from Nancy. This was in reference to our work and interactions with the Department of Education and sexual wellness education programs. Her question is, do you ever partner with the Rape Prevention Education RPE prevention group in public health to work with schools? They may have set connections to work with, and they have financial resources as well.
I'm actually going to refer that question to Suzanne because she was working with the work group that was addressing that activity. Suzanne, can you jump in and respond to that, please?
We do not have a relationship with that particular entity that she mentioned, but I'd love to get more information on that for sure. If you can just please send an email my way, Nancy, with the details, that'd be great.
She said sure. And that's the last question I had in the chat box. If there's any more in the public, that'd be great.
At this point, if anyone wants to ask a question, you can go ahead and unmute yourself and just ask the question. Stop sharing so that we can see. If you have any question, just go ahead and I think raise your hand and I can unmute you, or just go ahead and unmute yourself manually. Okay. There does not seem to be any questions. Did I hear someone?
Yes, this is Suzanne. This is the other Suzanne.
Oh, hi, Suzanne.
I have a question for Glenn. In reference to dental, is there any tracking of the number of cancellations of dental appointments by the providers?
Cancellations by the provider? I think that's one of the challenges that we've experienced as we've started looking at dental care. Is we only have access to a small piece of the whole equation. We only can see the bills that are coming in, so we have some data about cancellations, because if the client fails to show, we get a bill, but we don't have data about if the providers themselves are rescheduling or canceling. So I think that's something we'll need to be looking at as we do our work. I think all of us recognize we don't really know a lot about how the dental world works. And so we're going to start introducing ourselves into that process to try to make some improvements.
I think figuring a way to monitor that, considering because we do the transportation in Newcastle, and just in reference to the information that we get regarding that, that would be something I think would be an important item to begin tracking and monitor, because it would have, I think, would have a different outcome and provide information regarding some of the metrics that you were referring to in reference to clients being screened for their dental needs.
Thank you for that suggestion. I just put it on my legal pad.
Thank you.
Thank you.
Can I ask an additional question? Outside of mental health, are there other core support programs that are being underspent or underutilized throughout the year? And then the flip side of that question is, what is meeting and maximizing that financial resources that they're provided per year? That might be a Brad question.
What was the last part of your question?
It was what funded services are fully utilizing their allocated resources per year?
Can I speak to that for a second? I think one of the challenges when you look at Ryan White funded programs is, we hear the mantra, Ryan White is the payer of last resort. So we're here to fill the gaps. So just because a program is not utilized highly doesn't mean that there's something lacking in the program. Anecdotally, I hear the reason we don't have a lot of mental health counseling being paid for through Ryan White is because those clients are getting their services paid for through Medicaid. They're getting them through DSAM, Delaware Substance Abuse and Mental Health. So, I think you need to think about that. The mental health program run by the consortium really tends to be using providers that have specialized skills. So we may have counselors there that are Spanish speaking, that the consortium has recruited to provide service, or the case manager is recruited and the consortium pays those bills. So it really is that safety net around mental health. I don't know, Brad, I hope Brad would agree with that.
Right, and that mental health line item for the consortium is $1,500. I believe Brad said they spent $900, so they actually did spend 60% of that budget line item.
And we do encourage folks, if they have health insurance, to utilize that first. But I know that that can be a real challenge, especially for folks with Medicaid, because there are not many mental health providers who accept that.
Thank you, Brad. I think Dr. Luda has a question for Arlene. You're
Hi.
unmuted, Luda.
Can you hear me?
Yes.
Thanks. Actually, after listening to Arlene's presentation, I was very impressed by the scope and range of the services that you are providing. And obviously, I think this must have changed over time, because initially you probably were focusing more on HIV disease, but now you're in the prevention side and also hepatitis C. So my question was, what are you doing to make sure that the face you present to the public extends to more than just HIV? Because I'm thinking, for example, somebody coming in for PrEP, they may not want to walk into a HIV clinic. They may want to walk into a sexual health clinic, and that may apply to other services as well, including hepatitis C. I haven't visited any of your clinics recently, but what is the public-facing face of your clinics? What does it look like?
So I think that's a really important question. I want to answer PrEP first. When the consortium and Division of Public Health started really initiating a goal of increasing knowledge and awareness of PrEP, both among the community and our patient population, as well as providers, we felt we needed to be involved in that process as the HIV experts in the state from a medical standpoint. However, having said that, provision of PrEP is a primary care responsibility. And we provide PrEP for patients many times who are partners in a discordant relationship. And so therefore we are taking care of that other partner from an HIV standpoint. Sometimes because we end up providing PEP, post-exposure prophylaxis, that person oftentimes will turn into a PrEP patient, and we will keep them with us. But quite frankly, Martin, that is not our primary goal. Our goal is to be a leader in that and to provide the support and the resources to help other providers. But that is not what we want to be doing on a broad scale. And so that's why we've worked with public health and with the consortium and other agencies to encourage primary care providers to become engaged in that process. From a Hep C standpoint, we work certainly with AMO, adult medicine, primary care, family medicine here within the own organization, and accept referrals for hepatitis C treatment. We, in that case, do not keep those patients. We accept the referrals from their primary care providers. We evaluate the patients. We get them on treatment, shepherd them through the process, and then return them back to their primary care providers. I do not have the capacity to provide ongoing care to a patient who is hepatitis C infected but not co-infected with HIV. We have worked very closely with Westside Health. We have used them as a transformation site for hepatitis C. We have worked with that organization to provide education, training. We provide support. We do accept referrals from them for Hep C when the patient is complicated, but our goal has been to train them to provide Hep C treatment as well. If the estimates in the state of Delaware are correct, there are somewhere around 13,000 patients with hepatitis C who may or may not need treatment, and we can't provide all of that. So again, our goal is to provide leadership and to provide mentoring and support, along with our GI practice groups, to treat as many patients as we can with hepatitis C.
Right, thanks. I think thanks for that clarification. And I definitely agree with the direction that you guys are taking, as providing leadership and working as mentors with the folks in the community. I guess one of the areas that keeps coming up as a challenge is those that are uninsured or significantly underinsured. And I think that's really where I was thinking, maybe I'm wrong, but do I look at you as a safety net for that kind of group, or how does that work?
Actually, no, you cannot look at us for that kind of work. In some regards, I mean, we cannot assume care of every uninsured patient for PrEP or for Hep C as an organization. I don't think that's an acceptable expectation. We do work with, if the patient falls within the charitable discount qualities that the organization has, we are able to do that, but then our staff work with the pharma companies and some of the supportive programs that they have to access the medications. So we actually have to work in the same way we do with HIV, that we have to work with that patient to find out what they're eligible for. And it's not just the uninsured, quite frankly, because especially when you're talking PrEP, some of these patients have very high copays that they cannot afford. And there is not the same resources, as you know, through Ryan White, where we have resources for an HIV positive patient. We cannot use those resources for a PrEP patient who is not HIV positive, obviously, or for Hep C patients that's not co-infected. There are not the same supportive systems financially or in our state or in the nation to provide support to that type of patient.
Right. I totally understand the situation. I think it's clearer now. Now, this is my last question. Earlier last month, I was in New York for a NASDAQ meeting, and we visited one of the area sexual health clinics, and this is what really got me thinking about your clinics. They operate out of a health system just like Christiana Care, but I think they also are attached to a medical school, so they have access to fresh physicians that are still in the process of being of getting into practice, and they have set up what is a very comprehensive sexual health clinic. So my question to you really is that something that you think is possible with our setup in Delaware, or is it just something we cannot do?
I would not be in a position to answer that. I can tell you that we do work with residents who attend our PrEP clinic, and our goal there, especially family medicine and internal medicine residents, is to teach them to do sexual histories, to teach them how to manage a patient on PrEP. But as far as doing a broader context of sexually transmitted disease evaluation, that would be something that would have to be taken up with a different leadership that's above my pay grade.
Okay, all right, thanks.
There are no more questions in the chat box. Is there anyone else?
All right. If there